All right, we've reached the half-hour mark, so let's get started. Welcome everyone to this week's installment of AMSSM's National Fellows Online Lecture Series. My name is Haruki Ishii, one of the sports medicine physiatrists at New York University. I'll be your moderator for tonight. This lecture series is sponsored by the AMSSM Fellows Online Education Subcommittee, co-sponsored by the Education Committee and the Fellowship Committee. So tonight we'll be discussing altitude and then dive medicine. Before we get into our topic for tonight, I want to remind everyone of next online fellow lecture, which it will be on MRI lumbar spine. And we actually skipped next week, but this lecture will be scheduled on Wednesday, February 25th at 8:30 p.m. Eastern Time, and will be given by Dr. Olfade and will be moderated by Dr. Frank. The goals of this National Fellow Online Lecture Series is to serve as an adjunct to your individual fellowship program education and to provide sports medicine fellows with direct access to learning from experienced AMSSM members and guest speakers in a variety of formats. Also, this is meant to assist in CAQ exam preparation. Some housekeeping items. So please mute your devices, microphone, and turn off your video. You can submit your questions at any time throughout the chat, function, and feel free to include your name and program if you wish. At the end of the talk, I, as a moderator, will ask questions during the Q&A based on the questions submitted. Please also complete the evaluation at the end of the lecture. One of our new efforts is to facilitate more input from our audience, and there are a couple ways to do this. So first, a web link can be found by going to amssm.org, click the Education tab, and then select Fellow Online Lecture Series. This link is near the top of the page as seen in the screenshot. Second is by scanning the QR code. It should take you directly to the form to fill out. When filling out the form, we ask that you please keep in mind that the primary goal of this lecture series is to assist in CAQ preparation for fellows. And now I'd like to introduce you to our expert speaker tonight, Dr. Brian Kim. So Dr. Kim is an associate clinical professor at UC Irvine School of Medicine in the Department of Family Medicine and Orthopedic Surgery. He serves as the head team physician for UC Irvine Athletics and is the director of the Primary Care Sports Medicine Fellowship. Dr. Kim currently co-chairs the top 120 articles for fellows subcommittee for the American Medical Society for Sports Medicine and was recently honored as an AMSSM International Traveling Fellow to Korea. His academic interests include medical education, sports nutrition, and conditions related to female athlete triad. He holds a master's degree in sports nutrition from Columbia University. Outside of medicine, he enjoys spending time with his family, including his three children, ages 2, 4, and then 6, and following League soccer. Now, without further ado, please welcome Dr. Kim.
Thanks for joining me. This is a great topic for CAQ prep for those who are taking it this year or recertifying like I am at the 10-year mark. It's always a good review for me as well. So this is a picture of Alex Honnold, American rock climber, best known for his free solo of El Capitan, seen here ascending a sea cliff in Greenland. This is from a documentary called Arctic Ascent, great watch. So here's our outline for today. We'll start with some topics in altitude medicine. We'll take a brief side quest to cold injury, which is related to altitude medicine, but of course can happen at other elevations. And then we'll change gears and take a look at some topics in dive medicine. Apart from the CAQ, these are relevant because, even if you don't live at altitude or in regions where scuba is accessible, you may likely encounter those who are going to seek your guidance as they travel for these activities. And you yourself, might participate as well. So I have no disclosures financially. I did use some generative AI in part of the creation of the case text. So our first case takes us to Breckenridge, Colorado. This is a picture of the run of the Santas held every year, where a 24-year-old traveled from sea level to that city at about 3,000 meters. The next morning, she developed headache, nausea, dizziness, and fatigue, but no cough or chest tightness. Vitals are listed as we see there, a little bit low on the O2, but not too bad. And the exam is relatively unremarkable. So we ask what the next step in management is. A is immediate descent and giving dexamethasone. B would be giving O2 and nifedipine. 3 would recommend rest, oral hydration, and considering acetazolamide. D is starting antibiotics for presumed pneumonia, and E would be hyperbaric treatment for decompression illness. And we'll review these cases at the end. Second case for altitude, we have a 23-year-old soccer player traveling to Peru this time from sea level. And a few days in, she develops progressive shortness of breath, chest tightness, and decreased exercise tolerance to the point where she's now breathless walking across the hotel lobby. She does have asthma, but didn't bring her inhaler. Her vitals are a little bit more abnormal with tachycardia, tachypnea, and SpO2 at 82%. On exam, she does appear tired and she has crackles, but no wheezing on exam. So this case asks, A, do we give her albuterol and reassess? B, do we give inhaled corticosteroids? C, do we recommend immediate descent and giving supplemental O2? D, prednisone for asthma exacerbation, or E, encouraging rest and oral hydration. So when we talk about altitude physiology, the principal factor that drives the physiology of altitude is a decrease in barometric pressure with ascent. Here we have the equation for the partial pressure of oxygen, which is directly proportional to the fractional of inspired oxygen, which is going to remain stable at 21%, about 21%, even at altitude, and also directly related to barometric pressure. Probably should set a little bit of trigger warning. There's a lot of science and equations in this talk, so fair warning. So as the barometric pressure decreases, there's less total air pressure and fewer oxygen molecules per breath. And so this decreases the PO2 across the respiratory chain from the inspired air to the organs and the tissues, leading to some compensatory changes in oxygen content and delivery. And the graph on the right shows that relationship between the barometric pressure and the partial pressure of O2. A transcription factor, hypoxia-inducible factor, is responsible for some of these changes that we see related to hypoxia, like angiogenesis, erythropoiesis, and metabolism. And although, you're going to see similar types of responses, they're going to vary markedly person to person. The graph on the bottom right shows, potential changes in SpO2 after a few days at altitude. And you can see as we get very high, in the thousands of meters above sea level, in a normal person, you're going to see very low levels of SpO2 compared to sea level. So a few other changes to look at here. One of the main changes is in the respiratory system, and that's that hypoxic ventilatory response to increase minute ventilation, which includes tidal volume and respiratory rate. So the main change is an increase in respiratory rate. There are various hematologic factors, including hemoconcentration, to increase the density of RBCs. And then not immediately, but a few days after exposure to ascent, you're going to get a simulation of EPO. And so, these changes may be familiar to you as if you're familiar with the concepts of, acclimatization and performance, and the ways that altitude training or hypoxia training may induce metabolic alterations to improve performance, which is a little bit outside of today's topic, but related. So, first some pre-participation considerations, largely identifying potential contraindications for those who may be looking to, go to heights. Generally, we're looking at about 2,500 meters or above. It's challenging because there's a very wide spectrum of conditions that people can come with, and a relative paucity of information for most medical conditions. So just kind of four general themes to be looking at as far as conditions to be on the lookout for include those that would increase the risk for hypoxemia or impaired oxygen delivery at altitude. And these would include severe COPD, interstitial lung disease, and cyanotic heart disease. Those who may be at risk for impaired ventilatory response, so the case where ventilation may not increase sufficiently to demand. And so that would also include things like COPD, neuromuscular disease, and even carotid body dysfunction after surgery or radiation. Third category would be those at risk for pulmonary vascular responses to hypoxia, um, whereby the pulmonary vasoconstriction may induce some negative changes. So pulmonary hypertension, right heart failure are in this category. And these may predispose, as we'll talk about later, to particularly to HAPE or pulmonary edema. And then lastly, kind of a basket group, risk of hypoxia complications due to any underlying condition. So this could include sickle cell disease. It can include those with poorly controlled CAD, heart failure, as well as high-risk pregnancy. So there's a great review article referenced here and in several other slides with, you know, pretty detailed information about a lot of different conditions. As you can see, it's very busy. I put it here not to go over it, but just to show you, what you can look for. But, practically speaking, it's pretty difficult to further risk stratify high-risk individuals. So the practical advice is to, just have them do some graded exposure to high altitude in safe settings. Um, and safe settings would include those where medical care is available and descent is easy. So ski resorts are, pretty good for that. And so the idea is to get to altitude, monitor symptoms, rest, check O2, see what your symptoms are like. And then if you're feeling okay, consider moving up in altitude or increasing your physical activity at that particular altitude. There's not really any great data to support the efficacy of pre-acclimatization in these particular high-risk individuals. Generally speaking, for low-risk individuals, those who do not meet any particular high-risk criteria, and these are all fairly straightforward, make sure you're traveling with your meds, particularly those that may be needed on an PRN basis for exacerbations. Be aware of the potential for device malfunction. That could be your glucometer, your CGM, insulin pump, or even a metered dose inhaler. Some of these have not been tested at very low temperatures. So awareness of any potential backup options would be helpful. And then being aware of potential side effects with common travel meds, particularly acetazolamide and dexamethasone, which are going to come up several times in the treatment and prevention of these conditions. So I do want to talk about a few of these conditions that I think are common and that you will, very likely encounter. So asthma, as we all know, cold and dry air can trigger an asthma exacerbation. Interestingly, those with asthma actually have fewer medical exacerbations and decreased mortality at altitude. And there are many, uh, you know, conditions that we think are related to this, but those include less allergens at altitude, so less pollen, less pollution. There's decreased air viscosity, so air moves a little bit better, and there's more UV light potentially, kind of getting rid of any pathogens as well too. OSA is not necessarily worse at altitude, but kind of a related condition. Central sleep apnea, characterized by periodic breathing, can get worse at altitude. So, kind of be aware and certainly encourage the continued use of CPAP if they are using that. And there are some medications like acetazolamide that can help with periodic breathing as well. DVT and PE are well known to have higher risk with altitude. This is likely multifactorial, including maybe prolonged hypoxia, immobilization, dehydration as well. And then sort of a controversial topic is sickle cell trait. We talk about this a lot as far as, NCAA considerations. It is generally safe, although there are numerous case reports, particularly with professional athletes who have experienced, significant morbidity as a result of this. So one example is Ryan Clark, pictured here, who, when he was with the Steelers, traveled to Denver. I'm sorry, traveled to Denver in 2007. Had severe pain. Actually, was not initially diagnosed. When a few weeks later, was actually diagnosed with splenic infarct, and ended up having a splenectomy. Um, Thereafter, his coach, Mike Tomlin, would not permit him to return to Denver again, although he did continue playing successfully in the NFL. And you'll see him on TV, like on ESPN, commentating as well. So, our high altitude illnesses, generally we're talking about, 2,500 meters and above, but certainly this should not be excluded. Or the idea should not be excluded in travelers at areas less than 2,500 meters. Just a quick graph of some of the local resorts in California that we might go to. Some of the highest peaks on each of the seven continents, the seven peaks, just to give you an idea of just the variations of altitude that you're dealing with. If you're talking to somebody who's going recreationally to a ski resort versus somebody who might be doing a very high altitude trek. Three illnesses that we talk about are acute mountain sickness, high altitude cerebral edema, and high altitude pulmonary edema. It's important to know that AMS and HACE, as we'll call it, they exist on a spectrum. They are related to the same pathophysiology, with HACE seen as an endpoint of AMS. And although HAPE sounds a lot like HACE, it's actually a separate pathophysiology and may or may not coexist with AMS HACE. There is certainly a relationship between how high you get and the likelihood of AMS. So this study looked at those climbers in the Alps, and there's an increased prevalence with higher elevations. And how fast you get there, as we'll see when we discuss our risk factors for AMS, is important too. So those who are flown into a high altitude are much more likely to get AMS than those who ascend more gradually. As far as the why, the pathophysiology, the two main considerations are edema and vascular reactivity, and fluid balance, which is inadequate diuresis. So as far as how individuals may present, I point you to the Lake Louise classification. This is I believe, the most recent one in 2018. Four categories here. This one actually de-emphasize the role of sleep disruption as a part of the diagnostic criteria. Although it may seem like a diagnostic tool, it is mostly a tool for research, but it certainly can inform the diagnosis in clinical settings. The score can be used to indicate severity, with lower scores 3 to 5 indicating mild, 6 to 12 indicating moderate to severe. As you can see, both mild and moderate to severe AMS do not have any physical signs that are pathognomonic for it. So this is really completely a symptom-based diagnosis. Once we get to the end stage of high altitude cerebral edema, we do see that there's some CNS signs that are characteristic of that. So, it's important to know that there is no diagnostic gold standard. And so even though we have some of this guidance, these criteria, generally speaking, if someone travels, from sea level to a high altitude and they're not feeling great within hours to days, and it's affecting their activities, it is likely AMS. It may worsen within the first day or two, but typically, if there's no further ascent after the onset of symptoms, the symptoms will generally abate or plateau, particularly in milder cases. Very few cases do progress to full haze, seen in less than 1% of cases. And certainly with any concerning neurologic signs, so for example, ataxia, altered mental status, encephalopathy, and at very high altitudes, it is haste until proven otherwise. And it is important to note that focal neurologic deficits, like unilateral weakness, are less common. So getting into the treatment, and we're focusing right now on that HACE or AMS HACE spectrum. We'll talk about HAPE a little bit later. Um, this is clearly, descent is going to help no matter what the symptoms are. It's not always necessary, right? Mild symptoms will often abate on their own, and it may not be worth it to descend just to feel a little bit better. But this is a strong, evidence-based recommendation, grade 1A. So for those with mild to moderate symptoms, again, descent is not always needed. Just think of how many people go to ski resorts, and many people will get symptoms, but very few will have to descend. So general analgesics like Tylenol and ibuprofen can be helpful. Acetazolamide may be helpful, but it is better for prevention. So, in terms of any potential test questions, this is really a symptom limited disease as far as mild AMS. Once we get to more moderate or severe symptoms, and again, the diagnostic criteria, Lake Louise symptomology can be useful for this. That's where supplemental O2 really comes into play. And that's going to be the main answer for sort of moderate AMS, getting that SpO2 above 90%. So, rather than describing or advocating for any particular type or flow of oxygen, you really just want to get it above 90%. We don't want to go higher than that because the benefit's going to plateau and you'll start to increase your risk of oxygen toxicity. Dexamethasone and descent can be indicated as well in these scenarios. And then once we get to the more clinical endpoint of HACE or cerebral edema, that's really where very clearly immediate descent and dexamethasone are strong recommendations. The lines below that, O2 over 90%, this is really if you're awaiting descent or if descent is not possible. Same goes for the mention of the use of a portable hyperbaric chamber. Again, if you're going to have descent or going to have transport down, but you have some time, you have a hyperbaric chamber, that's where it may be helpful. In terms of prevention, the Wilderness Medicine Society, that's where these guidelines come from in 2023, gives us a table to try to risk stratify travelers to altitude in terms of three categories: the history of altitude illness, their sleeping elevation, and the ascent rate. And so when it comes to the risk factors for AMS, it is the elevation that you sleep at, not the highest that you travel to in a particular day, that is going to be the bigger factor. And you're going to see this 500 meters per day a lot. And that is kind of a threshold used to identify those who may be higher versus lower risk if they're going above or below that distance in altitude per day. It is important to note also that, although, there's clear categories here, history of altitude illness does not necessarily mean that you're going to be high risk in future ascents because there are modifiers too, right? So you can take it slower, you can have a lower target elevation, which are probably going to be bigger factors in decreasing that risk. Interestingly, fitness and youth are not protective in terms of AMS or HACE predictability. So regardless of what risk you're in, these are some general recommendations. So at altitudes above 3,000 meters, recommend no more than 500 meters of ascent per day, focusing mostly on sleeping altitude. rest days every couple of days. And then again, yeah, so there's a mention of climbing high and sleeping low. So you'll see these strategies, for example, with a sample Everest ascent. You'll go to several base camps during the day, but eventually return to a slightly lower elevation to sleep. Stage ascent is a strong recommendation, although it doesn't have high quality. Here's a picture of the Everest Base Camp. So there is some evidence that staying a few days at a moderate altitude, up to 3,000 meters, before further ascents can be helpful. Less evidence for those who may be going to lower altitudes. This doesn't quite apply to Everest. Everest Base Camp itself is at about 5,000 meters. And so it definitely breaks some of those rules as far as the risk of AMS and HACE. A strong but low evidence recommendation for the benefits of pre-acclimatization, and this describes repeated exposures to hypoxia in the time preceding the ascent, with more frequent and longer durations of hypoxia, probably more beneficial. They recommend against hypoxic tents, and you'll see these are out there. To be honest, if you take care of athletes like collegiate runners, it's not uncommon for them to, on their own time, buy these and try these themselves too. So there's not really many studies examining this particular question. There is considerable literature on the use of hypoxic conditions to improve performance at low elevations, like at sea level, but relatively little examining hypoxic exercise for improving exercise performance at high altitudes. So those who may be identified at moderate to high risk, that's really where the acetazolamide comes into play. This is going to be our big hitter when it comes to AMS HACE prevention. It has a slightly lower recommendation in children, but is still the main medication to be used. And acetazolamide actually, in several ways, truly facilitates acclimatization. So it has a diuretic effect to decrease fluid accumulation. It induces a metabolic alkalosis to counteract the respiratory alkalosis at altitude, lowering blood pH. And that lowering of the blood pH, the acidosis acts as a respiratory stimulant as well, to increase that respiratory rate, to increase the minute ventilation, like we talked about before. Dexamethasone can be used as an alternative if there is a contraindication to acetazolamide. Or in high-risk situations. So the one that this paper describes is those who may be in acute search and rescue situations where they can't wait. They got to go from whatever elevation they're at to high up a mountain to be deployed in search and rescue. And so those they may take both acetazolamide and dexamethasone. Acetazolamide does have a sulfa cross-reactivity, but the true incidence of allergy in those with a reported sulfa allergy is fairly low with acetazolamide. And then, for all of these, there are going to be some lower grade recommendations. I don't think that they're too important to remember, particularly for CAQ questions, but just be aware that, basically any of the above don't work. You can try other things like ibuprofen. And there are also several other supplements or medications that are not recommended. So moving on from AMS HACE to HAPE, or high altitude pulmonary edema. So this is a different pathophysiology. So this relates to an exaggerated hypoxic response of pulmonary vasoconstriction. Basically, fluid accumulates in the lungs faster than your lungs can clear them. And so this diagram on the right side shows the far right bar at normal 21% FiO2, the baseline clearance rate of fluid. And on the left side, kind of mimicking hypoxic conditions, decreased alveolar liquid clearance with increased time exposure to hypoxia. So, the presentation of HAPE would be that of an unacclimatized lowlander ascending to 2,500 meters or above with a variety of conditions, including dyspnea out of proportion to previous experiences. Our case describes somebody with shortness of breath just walking across a room. They may have a non-productive cough. In more severe cases and with progression, there's kind of this pink frothy sputum that's described. It's typically within 2 to 5 days of elevation gain. This is actually the most common reason for death from altitude illness. And it is separate from AMS and HACE. So, in a lot of cases, it is going to coexist. But AMS HACE is not necessary for the development of HAPE. As far as treatments, kind of like with, HACE or severe AMS, descent and O2 above 90% are important here. Again, the use of a portable hyperbaric chamber can be utilized if if there's a delay in descent or if descent is not feasible, and if supplemental O2 is not available as well. The pulmonary vasodilators like nifedipine and tadalafil, CPAP, they're going to be lesser considerations if, again, none of the above are available. And so just briefly, how does a hyperbaric chamber work? It basically increases barometric pressure, increasing the partial pressure of inspired oxygen, essentially reversing kind of what is happening with the physiologic response at altitude. These soft wall chambers shown here typically operate at about 1.3 to 1.5 atmospheres. Whereas as we'll see when we talk about dive medicine, the more rigid metallic chambers can get much higher pressures. And so in HAPE, there's no role for acetazolamide, beta agonists, or dexamethasone or diuretics. So really, the thing to remember for pulmonary edema is descent and oxygen. HAPE prevention, kind of that idea of gradual ascent, very similar to what we talked about with AMS and HACE. This is where the pulmonary vasodilators like nifedipine are key due to the role of excessive hypoxic pulmonary vasoconstriction in the pathophysiology of this condition. Tadalafil, dexamethasone, less evidence for that. The mechanism for dexamethasone for HAPE prevention is also not clearly known. So those have lesser recommendations. Interestingly, acetazolamide is not recommended for prevention of high altitude pulmonary edema. And that's a fairly strong recommendation, grade 1B, with the exception of a particular subset called re-entry HAPE. And that's for somebody who lives normally at altitude, travels to lower elevations, and then develops pulmonary edema upon rapid return to the residence. So I know that I've mentioned a lot of medications here with no dosages. I didn't want to overwhelm you with numbers. I doubt that would be a part of any CAQ questions, but the references, particularly this Wilderness Society position paper, does have all that information. All right, so we're going to pivot. We'll travel to the fictional ice planet of Hoth. This is a shout out to my kids. Who aren't watching anyway, but they've been really into Star Wars. So in this case, we have well, you're on a rebel base. Your buddy goes out for an afternoon patrol. It's getting dark, so you go out and look for him. He's confused, cold, and speaking slowly. On evaluation, he's shivering. He's slow in his responses, but can follow simple commands. He's cold, pale, has a low pulse, and his respirations are slow. His clothes are wet from lying in the snow. So what's the most appropriate field management for this situation? Do we A, encourage him to walk to, generate body heat? Do we B, get his wet clothing off, insulate him, and apply heat packs to the chest and axillae? Do we C, rub his arms and legs vigorously to stimulate the circulation? D, put the heat packs on his hands and feet first? or E, give hot caffeinated fluids to stimulate alertness. So we'll first talk about hypothermia, defined as a drop of core temperature to less than 35 C, which is about 95 degrees Fahrenheit. There are different categories based on the estimated core temperature, as well as the clinical findings that may be associated with those. So, the big difference is going to be the difference in mental status between mild and moderate cases. The most likely scenario is going to be finding someone in the cold, particularly in a snow environment. This may happen in swimming races, triathlons, if the water is very cold as well, too. So, you know, appropriate clothing. I mean, this seems pretty straightforward, but it's the best protection against hypothermia. If the conditions do allow for this type of dress, where the base layer is going to take fluid away from the body, so the wetness away from the body, and then the outer layers are going to basically retain body heat. All right, so two main principles as far as the treatment. One is to prevent further heat loss. So get them out of the cold, protect them from the wind. It's not just the cold, but also wind that relates to risk of cold injury. The ground itself can be quite cold, so if it's possible, insulate them from the ground, the cold of the ground. Vapor barriers if possible, and then removing wet clothing can be helpful as well. And then the second main principle is to apply heat. If possible, particularly if you're limited in the heat sources, getting closer to the core through the axillae, the back, the chest are going to be more helpful. And that's going to be essential in a non-shivering person who is not able to generate their own heat, because essentially that's what the shivering response is, to try to generate heat. And so, we have here Han Solo, who cut open his tauntaun and threw Luke in there. So he probably checked off a few of these boxes, and then get them to a warm environment as soon as possible. So in cases of mild hypothermia, so core temperature 32 to 35, normal mentation, shivering, they're probably going to do well. So warm clothing, drinks with calories, and active rewarming. Drinks with sugar or calories are emphasized because really it's the calories that are going to be important to make sure that they have enough energy to continue shivering, because shivering does require energy in the form of calories. These individuals may not require evacuation to a hospital. They may do well on their own. As long as the risk factors are mitigated, basically, if they are taken out of the cold, risky environment. In terms of more moderate to severe cases, it's really important to handle them gently. Meaning, don't shake them, don't rub them. We do want to passively rewarm them slowly and get them to a hospital. Be aware of the potential for cardiac arrest with hypothermia, typically at temperatures below about 32 degrees Celsius. An important concept that informs why you need to be gentle with them, why you want to passively rewarm them, is a concept of afterdrop. So you can actually see continued decreases in the core temperature during the initial stages of rewarming due to return of cold blood from the extremities to the core due to peripheral vasodilation. And so you do want to make sure that you have that in mind. So our second cold case has an individual in the Rocky Mountains, cold, high winds. He's stranded because he's twisted his ankle. So a medical team is out there on foot. He has numbness and clumsiness in his fingers. They're pale, hard, and waxy with decreased sensation. And you're still in a cold, exposed environment several miles from shelter. So what do we do here? Do we rub the fingers vigorously to restore circulation? Do we B, place his hands in warm water for rapid rewarming? Do we C, cover with dry dressings, protect and delay rewarming? D, apply direct heat, like from a portable fire. or E, have them perform hand opening and closing exercises for perfusion. So this is a case of frostbite. So frostbite is defined as direct freezing injury of the skin surface, typically of the face, hands, and feet, in air below about -3 degrees Celsius, and it can occur in salt water in negative Celsius temperatures. Basically, the pathophysiology is ice crystal formation in tissues, causing cell damage, ischemia, and hypoxia. And really, ice crystal formation is needed. Um, the chart on the right is from the National Weather Service, and it shows basically in minutes how quickly you might get to frostbite. So on the x-axis, we have temperature variable, the y-axis, wind variable. So you can see how both of those will play in with colder and windier conditions on the right and the bottom. So damage can occur during freezing and reperfusion. So this will inform our treatment and understanding that if they're going to freeze again after you rewarm them, you should delay that warming because you may actually be doing more damage. And although this chart shows X number of minutes before you might succumb to frostbite, it can actually happen in seconds when you touch metal. So another reason not to like lick the metal pole because it's very easy to get frostbite by touching cold metal. And technically, tissue cannot be frostbitten in fresh water because it's technically not cold enough for ice crystals to form. But it can occur in salt water, which is a little bit lower freezing point, and it can occur once you remove yourself from the water. So there's, different definitions of severity of frostbite. So there are historical classifications of up to 4 degrees, but for field use, typically it's divided between superficial and deep. So, in superficial, we really don't anticipate any permanent tissue loss. It affects the dermis and the shallow subcutaneous layers, maybe white or gray, and the skin feels firm, but not like rock hard. And these will generally do well if treated with rapid rewarming. The severe cases, are where the skin is white and gray and feels hard and cold. Your entire fingers or limbs can be affected. Like the nose, the cheeks are also vulnerable. And you may not feel a pulse. And in these cases, you'll probably expect permanent tissue loss even with optimal rapid rewarming. So, in any case, thawing initially with body heat can be helpful. So the chest or the axillae. When available, you can then submerge in warm water, not too hot, for about 15 to 20 minutes. If the face is affected and you don't want to submerge your face in water, you can use a warm washcloth and make sure to rotate that. And after you're done, you want to air dry, warm air dry, and do not rub that skin. Additionally, other things not to do, and sometimes you see these things in like the media or like old movies, like rubbing the part with snow. Don't do that. Um, and certainly don't use like stoves or fires to thaw it because the person likely doesn't have full sensation, so you may get a thermal injury. And so important point is that tissue that's been frozen, thawed, and refrozen is severely damaged, and you may have worse injury there. Um, so a brief mention of non-freezing cold injuries. So unlike frostbite, these tissues do not freeze. So instead, it's kind of this protracted vasoconstriction and associated ischemia that can cause ischemia and reperfusion damage. So trench foot, cold, wet conditions of the feet, causing a swollen edematous foot. And then we have chilblains, also called pernio, which can occur after a few hours in cold and or wet conditions as well. So generally speaking, long-lasting effects are rare. Not as much emphasis on these because generally they're not as um, concerning as the freezing cold injuries of frostbite and hypothermia. All right, so we've got to get moving to dive medicine. Lot to cover here. So this is Ahmed Gabr. He holds a record for the deepest scuba dive ever, and this was in the 2014 in the Red Sea. He descended 332 meters, or over 1,000 feet. And to give you a sense of what we're going to talk about, it took him only 15 minutes to descend, but the ascent took 13 and a half hours. And so we're going to discuss why it's so important to descend slowly and in a staged manner. So in this case, we have a scuba diver with in the ED with numbness, weakness of the legs, and difficulty walking that began 45 minutes after surfacing from a fairly deep dive, 36 meters. He had multiple dives over days, no pulmonary symptoms, but he does have some decreased strength in lower extremities and diminished sensation. So do we A, get an MRI of the spine? B, do we give O2 and arrange for hyperbaric therapy? 3, do we give fluids? 4, do we give aspirin and steroids? Or E, do we place him in the Trendelenburg position and give diuretics? So, there's a lot of interesting stuff about dive physiology. Basically, what we do in scuba is we use compressed normal sea level air for respiration. This is a picture of the scuba regulator, which is a critical component. It reduces that high pressure air from a scuba tank to a breathable ambient pressure for divers, really enabling that underwater breathing, which is necessary for scuba. A few physics points. So Boyle's law describes that volume of gas is inversely proportional to its pressure. So P1V1 equals P2V2. And it's relevant because scuba delivers air at increasing pressures as the diver goes deeper. And if that air is trapped and can't be released, it'll expand as a diver rises toward the surface. And then Henry's law describes the amount of gas dissolved in a solution is proportional to the partial pressure of that gas. So as environmental pressure decreases when divers ascend, this can lead to nitrogen bubbles precipitating into the bloodstream. So, the frequency ranges of injury ranges a lot depending on, recreational versus expert dives. These are kind of the categories that we think about that are testable. So on descent, we tend to think about middle ear barotrauma. And on ascent, we tend to think about decompression illnesses, including decompression sickness and arterial gas embolism. The table on the left shows a series of recreational divers, where about 8% had ear-related injuries and about 9% other injuries, with only about 1% having decompression sickness. The right side is data from larger diving registries. These are probably more expert elite divers, showing causes of mortality. And so I think the important points to note are that pulmonary barotrauma, which is equivalent to arterial gas embolism, is at the top of the list, and regular decompression sickness is very low. So actually a pretty low, rare cause of death. So when we talk about the barotrauma of descent, often called middle ear barotrauma, as we dive, we create pressure gradients between the outer, the middle, and the inner ear. Here, this is the normal sea level pressures of 760 torr. As you can see in the diagram on the top, the greatest pressure changes actually occur in the first few meters, going from 1 to 2 ATMs in 10 meters. And every sequential 10 meters, you increase by an atmosphere, but percentage-wise, it's a lower relative increase in pressure. As we descend whilst doing scuba, we need to equalize our eustachian tube. This is an active process. You have to actively do it while you're descending, whereas it's more of a passive process on ascent because the increasing pressure in the middle ear will just on its own open up that eustachian tube. It's recommended to equalize the eustachian tube every half meter of depth change as you're descending. I've had a lot of practice with this because I've been sick recently, but we all know how to Valsalva, pinch and blow your nose. There are various, variations of this. The second one, the frenzel, you can pinch your nose and kind of make a guttural like sound. Um, and these are all things we probably just are already familiar with and doing unconsciously when we try to clear our sinuses. So as I mentioned at the surface, all three spaces are at 760 torr. Not far below the surface, if we don't equalize, the middle ear pressure is going to remain 760, whereas the outer ears get up to 820. At this point, the eustachian tube can get blocked and locked. If at this point the diver tries to do a forced Valsalva, they can actually either burst the round window, connecting the inner to the middle ear, um, and or have a TM rupture. And so this is why it's so critical to equalize that eustachian tube during the descent. Um, and if you have an acute, TM rupture, the vestibular response can induce vertigo and vomiting, both of which can be deadly. As we ascend, we'll talk about decompression sickness. This has been called caisson disease. This is a historical note named after the pressurized, watertight chambers used in the 19th century to help build bridge foundations and tunnels. So this is a schematic of the Brooklyn Bridge caisson. And how this works is that nitrogen is absorbed during descent into tissues, and then during ascent, the partial pressure of gas exceeds the environmental pressure, causing the bubble formation. And much of it can be filtered, but particularly in the cases of ASD or PFO, it can overwhelm the capacity or travel through shunts. There's a lot of potential manifestations. I'm just going to go through a couple of classic syndromes. You can reference this New England Journal paper for more details. But we have the bends, kind of the musculoskeletal complaints, the pathophysiology being unclear, the chokes or cardiopulmonary symptoms related to cough, chest pain, and shortness of breath, typically with rapid ascents. Cutaneous manifestations, as in the picture here, this kind of reticulated blotchy rash. There's inner ear DCS characterized by vertigo, ataxia, nausea, and nystagmus, and then spinal cord DCS. And this is what our case was referring to, where we had kind of symptoms of an ascending paresthesia and potentially proprioception affected and bladder dysfunction. So the other type of decompression illness is pulmonary barotrauma. And in less severe cases, we might just get some air in the mediastinum, pneumomediastinum, less commonly pneumothorax, but in the most severe cases, we'll get that arterial gas embolism. So that's kind of equivalent to the most severe sequelae of pulmonary barotrauma. And that's where bubbles leak through ruptured veins and can enter the systemic circulation, which typically has CNS impacts, the brain being most susceptible. And it is this rapid ascent, often panicked, that can lead to this. There's a lot of different symptoms that this may present with. Some may overlap with regular decompression sickness, but these are largely CNS symptoms. And about half will have signs of pulmonary barotrauma, but many of them won't. And so a question will arise, how do we distinguish between the two? So in this table, we have cases of decompression sickness on the left and cases of gas embolism on the right. And one factor is that if they have symptoms right on surfacing or immediately afterwards, it's much more likely to be a gas embolism than it is DCS. DCS can present, much later, a day or more later even. Decompression sickness also generally only occurs with dives deeper than 6 meters, with increased risk with longer and deeper dives. Whereas gas embolism is not related to the depth time exposure. It can actually occur with ascents as shallow as 1 meter. Practically speaking, it can be pretty difficult to distinguish between the two. And the good thing is it doesn't matter because the treatment algorithms are very similar or the same. So it's a lot to take in here, but the main distinguishing point is, are there mild or serious manifestation? The mild manifestations being kind of MSK, cutaneous constitutional complaints, which are generally treated with oxygen fluids and considering analgesics. Once we get to those more serious manifestations, that's really where recompression therapy is going to be the mainstay of treatment. And that's where a hyperbaric chamber comes into play. And so how that works in the treatment here is that it's going to enhance the diffusion gradient for inert gas from the bubbles back to the blood. This is a sample of from the naval guide showing just the stages of hyperbaric chamber use. This goes down to 2.8 atmospheres with several decompression breaks throughout. And the total duration can be between about 4 to 8 hours. So it's a fairly lengthy process. So prevention is key. So as we mentioned, you want to avoid rapid ascents. You want to avoid breath holding when ascending. So you want to make sure that you're breathing through your device and avoiding diving with any pulmonary diseases that may affect, air movement or increased risk of air trapping. Safety stops are going to be built into, scuba protocols, diving protocols. And while this is largely, computerized now, these tables have been used in the past to calculate residual nitrogen to take into account in people doing multiple dives. Basically, if you have residual nitrogen, you actually need longer or more frequent rest stops. And like in the case of our diver with the world record, we see how quickly someone can go down to their desired depth and how long it takes with prescribed stops to ascend back to the surface in a safe manner. So the saying goes, plan the dive and dive the plan. If there's one thing to take away, there is a hotline, kind of like poison control, 24 hours, 7 days a week, global, which will connect you to a network of nurses, physicians, and specialists to help triage you, work you through your treatment and connect you to specialty care nearby. So we'll go ahead and do our last case real quick. This is basically a pre-participation medical evaluation for an upcoming dive trip. And so there are several conditions here, and we're asked, which is a severe risk condition? Mild asthma, well-controlled, prior pneumothorax, well-controlled hypertension, well-controlled seizure disorder, and migraine without aura. Many of you have probably done this already, have a patient come in for a form to be filled out, or if you haven't, you certainly will. This is the most common form that's going to be used through a variety of different diving providers, PADI being the largest group organization. Basically, the participant is asked 10 questions, and if they're all no, that's it. They sign it saying, hey, I don't have any of these things. You don't have to see a doctor. So it's really up, the onus is on the participant, but if they do have any of the conditions, it does require a doctor's signature, and that's where you come into play. And ultimately, it's just you check approved or not approved. There are no modifying factors. You can't say approved with this consideration. You really just can say yes or no. There's all sorts of guides for this. This website has excellent guidance there. That's actually referenced in the medical pre-participation form with several categories where the severe risk conditions are probably the most important to be aware of. These are probably the strongest contraindications. Far too many to go over in detail, but here are a list of some of those. And although these are not strict contraindications, generally in most cases, this would lead you to check the no box on the diving physical. So importantly, panic attacks are really dangerous because they're going to increase the risk of breathing abnormalities and rapid ascent, which can lead to a lot of problems that we talked about. Obviously, shunts, Diabetics, the risk of hypoglycemia is a considerable concern and going unconscious. And a spontaneous pneumothorax is also a contraindication because in most cases, even if they have some treatment, does not necessarily eliminate the risk of a recurrence. And so, I would just refer you to this reference, and if you're in the situation where you're making that evaluation in clinic, take a look at that list there. So reviewing our cases really quickly, this is our runner traveling from sea level to Breckenridge. And I think the point here is that this is describing classic acute mountain sickness. So a recent ascent, headache plus nausea, dizziness, and fatigue. And so the answer here would be rest, oral hydration, and considering acetazolamide. The symptoms here are relatively mild. They don't rise to, cerebral edema. So more severe measures like immediate descent, dexamethasone, supplemental O2 are not necessarily absolutely needed. In our second case, this one is essentially describing high altitude pulmonary edema, high altitude onset between 2 to 5 days, and dyspnea at rest out of proportion to what they are used to. And so the answer here is immediate descent and the administration of supplemental O2. In case 3, we have our individual with hypothermia. And so the answer here is B, removing wet clothing, insulating, and applying heat. We don't want to walk him around because that may cause some hemodynamic shifts and after drop. Again, we were taught not to rub arms and legs. And we're taught that axilla, chest, and back are the best places to position heat source. Our case of frostbite. This is a case of pretty significant frostbite. And the key here is that this is a situation where the medical team is responding on to a call, and there's going to be a delay in their return because it's a fairly remote environment, miles away from shelter. So the answer here is C, because if you rewarm them during the return back to safety, there's a high likelihood that refreezing may occur, which may lead to worsening injury. In our first diving case, this is a case of decompression illness. And in this case, he's having neurologic symptoms, which may be spinal DCS. And so this is going to be a more severe presentation. Although MRI may be considered, there's actually not necessarily good evidence that it's going to change treatment. So you really go by symptoms. And the answer is B, administering the oxygen and arranging for the urgent hyperbaric therapy treatment. And our last case is a 38-year-old coming in for their medical evaluation. And so as we learned, one of these is a severe risk condition, and that's going to be B, the prior pneumothorax, whereas asthma, hypertension, well-controlled seizures, and migraine without aura are not. So it was a lot of information to cover. Sorry we went over a little bit, but I hope it's going to be helpful for you as you prepare for your CAQ and recertifications. Thank you.
Thank you, Dr. Kim, for kind of presenting such a dense topic within that 60-minute period. So I know it was kind of difficult, a lot of physiology to it. And these conditions may not be something that we often see in our clinic, but these conditions are certainly highly testable. And then I definitely saw a few questions on altitude and then also diet medicine on my recent boards as well. So certainly I think these are something that's good to kind of review it even right prior to the exam to make sure that you understand the difference between, AMSM, AMS, HACE, and then HAPE, and then other various pathologies. I don't see any questions right now. I know we passed 9:30 right now, but I just wonder if you saw any, I guess, recommendations in terms of return to activities after, patients suffering from these conditions, whether it's altitude illness or decompression sickness.
Yeah, so certainly for altitude, in the milder cases of AMS, mild to moderate cases of AMS, once they're stabilized, their symptoms are improving, you can, either increase your physical activity or reattempt ascent. But generally, in the cases of high altitude cerebral edema and pulmonary edema, it's not recommended to reattempt ascent at the same visit or visit to altitude. And as far as the decompression illnesses, some of those symptoms can be, fairly long lasting. So I think a medical evaluation would be recommended before clearance is advised. One thing I didn't mention is that, there are considerations that you shouldn't do airplane flight soon after a diving trip. Depending how deep you go, how long you're in the water, that is a rapid ascent. So you can actually trigger symptoms of decompression illness by getting on a flight too soon.
Cool. Thank you so much. Looks like no one has any questions, so looks like you covered everything. But thank you all for joining tonight, and thank you, Dr. Kim, for giving such a great lecture. So hope you guys have a great night, and then I'll see you guys in 2 weeks.
Thank you.
Thank you all.